Good morning, friends. Good morning. Yeah, it's always a pleasure to see you all on Sunday morning. I am Dr. Mohan Rajan. I'm going to chair this session, and we have some co-chairperson also, but I'm not sure whether they're coming. But anyway, we'll start the session on time. We have another 2 minutes. This is a session on inherited, degenerative, and surgical retina, free papers, and each paper is for 4 minutes. And the first speaker is Dr. Trisha, and I'll call her now. What about the other speakers? Are all there? Let me call out the speakers. Presenters. Mrinmay? Yeah. Pradeep? Vijay Kumar? Not there? Not yet come. Okay, fine. Trisha is there. Abhishek? There. Okay. Jaspreet? No. So Vijay Kumar and Jaspreet. Anushri? Yes, sir. Bilal Ahmed? नहीं है? Okay. Indranil? No. Shivayan Shivatsa? Yeah. Sujay? Sujay Herikar? No. So we have 1, 2, 3, 4, 5 as of now. Okay, we can start with this first speaker now that we have got time also. And the first speaker, Dr. Trisha, and she's going to talk to us on a pseudofovea formation in a pediatric case of toxoplasmosis retinopathy, a case report. You have to be a little louder on your mic because the AC, lot of extraneous noise is there, so a little louder, okay?
Yes. Good morning, everyone. I'm Dr. Trisha Shresht, second year junior resident from Prayagraj. My case for today is a 14-year-old female student resident of Prayagraj, Uttar Pradesh. Came with a chief complaint of diminution of vision, right eye more than left eye for the last 3 years, and a history of frequent change of glasses since the same time. History of presenting illness, the patient's chief complaint was diminution of vision, which was gradually progressive and painless since the last 3 years. She had a history of frequent change of glasses. She wasn't satisfied with them. And the patient's mother also gave a history of frequent episodes of fever with associated rashes, which was around 6 years back. Antenatal and birth history. The mother gives a history of high-grade fever in the third month of pregnancy, and the rest of the antenatal period was uneventful. The patient, the baby, was born at 9 months of period of gestation with a very low birth weight of 1 kg by a normal vaginal delivery, and there was also a history of NICU admission for the first 2 days. There was no history of vomiting, seizure, or loss of consciousness. There wasn't any history of contact with the pets. There was, although, a history of chickenpox in 2019, around 5-6 years back. Coming to the examination, general physical examination, the patient was built clean, oral hygiene was good, bowel and bladder habits regular. There were multiple scars on the body from the previous chickenpox infection, rashes. Systemic examination, it was all within normal limits. Coming to the ocular examination, ocular adnexa for the right eye was within, right and left eye was within normal limits. Ocular motility was full in all gazes for both the eyes. Sclera and conjunctiva was within normal limits for both the eyes. The uncorrected visual acuity for the right eye was 1/60, which showed no improvement with pinhole. And with left eye, it was 6/18 partial, which showed improvement to 6/9. The best corrected visual acuity, there was no acceptance for right eye, although there was an acceptance of -1 diopter spherical seen up to a vision of 6/9. Pupil was normal, and the light reflexes were normal and brisk for both direct and consensual in both the eyes. Anterior segment, there was no evidence of any flare or cells. IOP was normal and the vitreous was cleared. Coming to the fundus examination by indirect ophthalmoscopy, globe was present, media clear, optic disc was well within normal limits. There was a well-defined hyperpigmented healed scar, toxoplasmic scar at the macula in the right eye. Same for the left eye, the globe was present, the media was clear, and the optic disc was within normal limits. But there was a small, around 1 disc diameter, healed scar around the infero-temporal arcade. We are suspecting it to be the toxoplasmic scar. Here is the fundus photo of the right eye. As you can see the scar here. For the left eye, along the infero-temporal arcade. Then this is the OCT picture showing in the right eye the foveolar contour is disrupted a little. The intraretinal and the subretinal contour is also a little disrupted in the right eye more than the left eye. The investigations were ordered and the routine investigations were done, and it showed IgG positive for toxoplasmosis gondii, and the rest were all within normal limits. On the basis of the history, examination and investigations, we conclude the provisional diagnosis of the patient was healed ocular toxoplasmosis, and the poor visual prognosis was explained to the patient's mother. The patient was put on a regular follow-up. Then on a follow-up after 6 months, the vision in the patient showed an improvement in the right eye of 6/18 partial and 6/6 in the left eye. Following this, we performed a few investigations, including the perimetry, which showed eccentric fixation. On the basis of this history, examination and investigations, we come to conclusion that it was a post-toxoplasmosis pseudofovea formation. Since we all know, pseudofovea, as we all know, is a retinal locus, it is always usually more than one in patients, and we see these, this is a developmental, this is done by the brain when the patient's central vision is disrupted due to any cause like macular degeneration or anything. So in those cases, pseudofovea is formed, and there has been a few research, but there's always hope and scope for the same. Thank you.
Thank you, Trisha. Very nice presentation. Do you have a post after 6/18? Do you have any picture?
Sir,
after the vision improved?
Sir, the vision improved. The picture was similar. So,
similar.
Yeah. The scar was a healed scar only, and the picture was similar. So I didn't put it in the. But the fundus picture was almost the same only.
I'm a little surprised because of the so much of scar 6/18 vision.
Yes, sir.
Yeah, it's a very good. Actually, you should publish this.
Yes, sir.
Have you published?
No, sir.
No,
I
have you sent it for publication?
No, sir. I haven't yet.
You should do that.
Yes,
and it's very important. And what are the IgM levels?
Sir, IgM was normal. It didn't show any elevation at the point when we ordered the investigations for toxoplasmosis gondii. The rest of the torch profile was also normal only. Only IgG for toxoplasma gondii was positive, which was indicates the past infection.
Any questions from the audience? Any questions from the audience on this? Abhishek, anything? That's what I was also wondering, whether initially the vision was not taken properly, or I was wondering, because such a big scar, but even if the pseudo-fully eccentric fixation, how many people, we have seen so many people with eccentric fixation, they don't improve much. That's something which is, so how do you document pseudophobia?
Sir, we unfortunately we don't have a microperimetry or a scanning laser or ophthalmoscope, but we tried perimetry, and we concluded that this is eccentric fixation, and the vision was improved. Like, we did a follow-up.
Do you have a OCT picture? OCT you have?
Sir, when the patient presented to us, it's from then, and we have a picture here.
The other speakers have come, please let me know. Any other speaker has, some more people walked in now.
Yes,
yeah.
The OCT picture.
This is pre, no? This is OD, OS, this is OD only. OD
Yes,
only we
OD.
want. Okay. It doesn't show much scar actually.
Yes, sir. The macula doesn't have that.
Yeah. See, if you see the clinical picture, the OCT is not showing much scar there.
Much scarring at the fovea.
Yeah, wondering whether, it may be parafoveal or just because,
The scars.
or the vision was not checked properly, or the child didn't cooperate, or something like that. Anyway, whatever it is, it's a good presentation, and we'll go to the next speaker. Thank you very much.
Thank you, sir.
So, next speaker will be Dr. Mrinmay, and she'll be talking to us on a case of gyroid atrophy of choroid and retina.
Very good morning to all of you. I am Dr. Mrinmay Kutte, and today I'll present a rare case of gyroid atrophy of choroid and retina. So gyroid atrophy of choroid is a rare genetic disease of autosomal recessive inheritance. High prevalence is found in Finland, that is 1 in 50,000 cases. There is mutation of OAT gene on chromosome 10, which leads to deficiency of enzyme ornithine aminotransferase. There is 10 to 20-fold increase in plasma ornithine levels, and there are chorioretinal atrophic patches found in first decade with night blindness and myopia. And there is diminution of central vision due to macular affection and cataract found in second decade. So a 15-year-old male, Muslim by religion, born to consanguineous marriage, presented to our OPD with chief complaint of gradual diminution of vision in both eyes at night since childhood. And there was mild cognitive impairment and speech defect, and there was no family history of similar illness. On general examination, patient was conscious oriented. There was no pallor icterus, cyanosis, clubbing or lymphadenopathy. And rest vitals, all vitals were within normal limits. On systemic examination, CVS, RS and per abdomen were within normal limits. And on CNS, all cranial nerves were intact, and there was mild cognitive impairment and speech defect. On ocular examination, uncorrected visual acuity in both the eyes was 3/60, and best corrected visual acuity was 6/12 with -6 diopter per ad. Intraocular pressure was 12 millimeters of mercury. And slit lamp examination of anterior segment was within normal limits. On fundus examination, media was clear, cup disc ratio was 0.3, and there were patchy, sharply demarcated circular areas of chorioretinal atrophy with hyperpigmented margins in mid to far periphery with sparing of macula were found. To summarize with, a 15-year-old Muslim male born to consanguineous marriage presented with gradual diminution of vision at night since childhood, with past history of mild cognitive impairment and speech defect, and the positive findings of patchy, sharply demarcated circular areas of chorioretinal atrophy with hyperpigmented margins in mid to far periphery with macular sparing, we came to provisional diagnosis of gyroid atrophy of choroid and retina. And we differentiated it from choroideremia, retinitis pigmentosa, pathological myopia, and Beatty crystalline dystrophy. And patient was advised further investigation, like on blood investigation, 20-fold rise in plasma ornithine level were found, and rest urine, serum electrolytes and serology was within normal limits. On OCT, hyporeflective cystic spaces in inner retina were found, and on ERG, extinguished rod cone responses were recorded. We managed this case with eye drop dorzolamide 2%, 1 drop twice a day, tablet vitamin B6 40 mg twice daily for 6 months. Patient was advised arginine restricted diet, and parents were advised genetic testing. So what is unique in my case, that it is an autosomal recessive condition. There are markedly elevated plasma ornithine due to ornithine aminotransferase deficiency. There are well-defined scallop geographic areas of chorioretinal atrophy which begins in mid-periphery, which progressively enlarge and coalesce. So early recognition and metabolic intervention, that is diet and pyridoxine, they are essential to slow the retinal degeneration and preserve vision. So take-home message is early diagnosis, dietary modifications, vitamin B6 and genetic counseling are effective in management and further progression of disease. Thank you.
Good one, Mrinmay, and I just want to know, did you do any, what do you call, counseling? Found out that other members of the family, anybody is affected? You not mentioned that.
So there were no other members in family were affected. There was no
How
family
many
history.
siblings,
No siblings. Sir.
parents?
No, sir. Parents were not affected.
Okay, uncle, aunt, anybody?
No, sir. No one in the family.
No,
was
you are affected. Because I have presented, published long time back in 1988, and entire family of gyrate atrophy of choroid and retina, and they do pretty well with pyridoxine. Not pretty well means at least we can say. Anything you want to say, sir, Dr. Jain, sir? Anything you like to say? Yes, gyrate atrophy of the choroid and retina is something which is because it runs in the family and autosomal recessive, as you rightly said.
Yes,
So no other member in the family. I'm a little surprised about it.
sir. No, sir.
Because I had a patient where a family wherein all the three siblings were affected, the mother was affected, and the grandfather or grandmother were affected. Whole family, we published that in, yes, gyrate atrophy of the choroid and retina. Yeah. Absolutely.
Yes.
They have the pedigree chart. You need to do a counseling because the future is all. What is the age of the patient now?
So he was 15 years old.
Because we have to make sure, because these people, they will go for when they are 20, 21 now, especially Muslim, they get married early. So we have to counsel them accordingly, because this is going to be propagated to the next generation as well. So the genetic counseling is very important. I'm sure you will be having some a lot of genetic counseling is going on now, and a lot of work is going on now on this field as well. And they are doing gene therapy, and so many other factors are coming into play. But something which is very, very necessary with genetic counseling, you need to counsel the entire family, that making sure that they don't, even if they get married, they should not get any children. That's what you have to tell them. So I think the genetic counselor, there are special, in Chennai and other places also, so many other places, there are special ocular genetic counselors, only for the eye. And you can contact them, and online also they can do. Shop Eye Center they have. In Bangalore we have Dr. Rajini Bhattu, who is doing a lot of work on this. She's got her own thing, and she used to do come to Chennai to our center as well. Then we have Dr. Kumar Manikvel, who was formerly in Shankar Netralaya, now in Chennai. And a lot of work is being done on this field. Because genetic counseling is something which is very important. You should not neglect that. So anything you want to add, sir, for the gyrate atrophy? Yes, sir.
Thank you, sir.
Thank you, thank you. Very nice. So we call the next speaker, and a rare case of bilateral disc drusen with peripapillary choroidal neovascular membrane in young Pradeep. Yeah, Pradeep. Yeah.
Good morning all. Today I will be presenting a case of
Little louder.
Today I will be presenting a case of peripapillary CNVM in a young female patient. Coming to the case, patient was a 20-year-old female presented with decrease in vision in left eye since 5 days. There was an associated headache with the holocranial nature. There was no any medical history or any significant past history. On examination, right eye was within normal limit with normal intraocular pressure. Left eye was 612, not improving. And contrast sensitivity, mild decrease was there in the left eye. On examination, right eye fundus, the media was clear. There was crowded disc with indistinct margins. Cup disc was obliterated with foveal reflex present, and macula appeared normal. Whereas left eye fundus showed us crowded disc associated with indistinct margin, and cup was obliterated with peripapillary yellow lesion temporarily with subretinal hemorrhage. Also, we noted that superiorly the localized small round elevations there was suggestive of superficial drusen were noted. On examination and evaluation on clinically, we decided it to be both eye optic nerve head drusen with left eye peripapillary CNVM. So further evaluated with B scan, wherein we noted that bilaterally there were hyperechogenicity with high reflective in nature noted. Also, fundus autofluorescence showed hyper autofluorescent round structures in disc with irregular edges in both eyes, which were more significant in the left eye. And right eye OCT of the disc showed us disc elevation with signal poor core surrounded by a hyper reflective margin, and back shadowing was noted. In left eye also, disc elevation was significantly noted with signal poor core surrounded by hyper reflective margin and back shadowing. Also, there was SHREM with subretinal fluid noted. And octa of left eye particularly showed us the vascular network in the deep retinal plexus in the slab, which was suggestive of type 2 CNVM. So treatment was decided to be left eye intravitreal anti-VEGF appropriately was decided, but what we noted was like patient didn't follow up with us. So I want to go through a few discussion on the optic disc drusen. Basically, they are the acellular deposits of calcium, amino and nucleic acids and mucopolysaccharides causing chronic optic neuropathy in a long duration. These are usually located in the lamina cribrosa in the optic nerve head, may be superficial or buried. So epidemiology incidence varies from 0.4 to 2.4%, can be unilateral or bilateral, mostly asymptomatic. Location wise, nasal to the disc are more common. So with age, we have noted that the visibility of the disc drusen increases. For example, in the 7th or 8th decade, it will almost be seen in most of the patient. So these are often buried in the young age, so visible at the disc surface in 2nd to 3rd decade normally. So precursors are small optic cup, small scleral canal and small disc area. Pathogens would be any genetic predisposition, and as I mentioned the previous, chronic obstruction due to the small cup or scleral canal. So this in turn causes extrusion of the calcification material, then formation of the optic drusen, further damaging the exoplasmic flow. So clinical features of any such cases with only disc drusen would be asymptomatic and very rarely may have 24 to 85% of adult population with visual field defects. Associations would be any kind of glaucoma, papilledema, RP, angiostrix. Systemic, there are noted that rarely algilar syndrome, pseudoxanthoma elasticum and phacomatous. Even one of the cases had noted that disc drusen are associated with the idiocranic intracranial hypertension. So complications of disc drusen would include optic ischemic, non-arteritic ischemic optic neuropathy, vascular occlusions, peripapillary choroidal neovascular membranes, retinal hemorrhages. So underlying optic disc drusen, basically they cause the vascular compression, altered autoregulation, thus leading risk of vascular complications. So the pathogens would follow the similar type of CNVM, is direct mechanical compression, impaired peripapillary circulation, thus increasing the level of VEGFs and forming the type 2 CNVM. So most of the peripapillary CNVM were treated with anti-VEGFs and had a good result, which required 1 to 3 number of anti-VEGFs. Differential diagnosis would be congenital disc anomalies, infiltrative lesions, vitreopapillary tractions, LHON. Also the recent entity PHOMS, that is peripapillary hyperrefractive ovoid mass-like structures, can also mimic like a optic disc drusen. Also tilted disc, MNF, crowded disc and idiopathic intracranial hypertensions. Just like differentiating features from PHOMS and the optic disc drusen include, in PHOMS, which is a newer entity, OCT finding seen are, there will be papilledema associated and tilted disc would be there, and maybe having the optic disc drusen and pseudopapilledema. These correspond to herniating nerve fiber actually, and lateral bulging into the peripapillary retina would be seen. Some hypothesize that these are the precursor lesion to the optic disc drusen.
Yeah, time is up. Yeah. Very nice, Pradeep. Just wanted to know, you have done all the TSR.
Is CNVM, how often is it associated with optic disc drusen? How often CNVM is associated with pseudo?
What is the incidence of CNVM?
It's quite rare, sir. For that we took it a very that to bilateral with optic disc drusen. Association in the young female was rare because the optic disc drusen itself is a long duration process where it causes the ischemia by the exoplasmic flow obstruction. So it was in a young female of 20 years. It was little rarer entity which we studied.
Yeah, because I haven't seen it.
Yes.
I have seen lots of drusens. I haven't seen CNVM. Yes. And number two, was there a leakage on fluorescein angiography?
Yeah. Why you didn't do fluorescein and ICG?
Since we got it in the opta, and also patient was little apprehensive with the 20-year female, and she was somewhat apprehensive with the invasive procedure. So with opta, we just went ahead, sir.
You didn't show? Did you show the optom?
Yes, doctor.
Yeah, I saw that photograph.
Okay.
But there was there. You see, there is no need of anti-VEGF if there is no leakage at all.
In opta, we had the active network, sir, with subretinal fluid.
No, that is shown in the OCT also. Yes. We saw that. Yeah. So anti-VEGF, what anti-VEGF you gave?
Ranibizumab. Ranibizumab.
Ranibizumab, okay. I think Eylea is the better, aflibercept is better for this, long acting.
Only one dose?
Sir,
No.
actually this patient we could not follow up because she lost a follow up, sir. Only one single this was there. But when we just called by the telephone, they told that they got treatment somewhere else.
Somewhere else.
Yes. And the visual prognosis
Vision.
was, she was stabilized, like
What is the vision?
she didn't tell the particular, she told they have improved, sir.
Okay.
Thank you.
Any questions from the audience? As long as the OCT shows activity. My suggestion is aflibercept for these patients. The longer acting and rather than ranibizumab, it works very well for these patients. I'm not sure about Vabysmo now, but we don't have very good results with Vabysmo. But aflibercept Eylea is probably the best for this. But as long as we need to follow up on long term, because there's a possibility the same CNVM can occur in the fellow eye as well. So once you have optic nerve drusen in both eyes, and that's a big problem. And FFA ICG is a must. The reason why we need to do, because FFA ICG is we have to document the nature of the CNVM, number one, and it will be a baseline documentation for you to know in the future. Since the patient is quite young as well, you need to document, and probably subsequently you can do OCT, OCTA, whatever it is, but baseline angiogram is very, very important, right?
Yes.
Okay, we go on to the next speaker, and Vijay Kumar Moria is there? No. Then we go on to Abhishek. Number 5, sir. Child and his family with Stickler syndrome, preventing sight-threatening complications. Abhishek Jain.
Good morning, everybody. I thank the organizing committee for giving me this opportunity. So, I have a series of 3 cases from the same family in which a father and his 2 sons were involved with the same disease. My presenting child was a 12 years old guy who was living in the outskirts of Delhi in a rural area. He came to me after a history of 4 months of loss of vision, because initially he was taking treatment with some local physician who was just giving him some eye drops, and a patient of mine referred him ultimately to me for an ocular checkup. So he presented with a vision of hand movements close to face with inaccurate projection of rays. Another eye was high myopic of -18 diopters with best vision of 618. Anterior segmentally, he had a mature cataract with no view of the fundus in the right eye. Left eye showed anterior vitreous face, multiple vitreous wheels and membranes with a liquefied vitreous. So the ultrasound of the right eye showed a closed funnel RD which was non-operable, and it was going into thysis bulbi. Other eye was high myopic with axial length of 31 mm, and fundus examination showed typical lattice degenerations for which he was undergone a prophylactic laser barrage. So looking initially, this child looks like a simple case of pathological myopia which we would have seen in our everyday practice, and since he had a trauma, he underwent an old retinal detachment. But what is interesting is that you should see he had more of vitreous degenerations, excessive degenerations in his other eye, which is clearly visible, and lot of liquefied vitreous in a comparatively young patient. So it gives us a suspicion of some vitreoretinopathy, some vitreous syneresis kind of pathology, and what comes in our mind is these all differential diagnoses like Stickler syndrome, Marfan syndrome, Ehlers-Danlos, Wegener's. So in Marfan's, you can clearly see you have Marfanoid features, which was not there in our case. And in Ehlers-Danlos, there is skin elasticity, joint hypermobility, which was again not in our case. This case more or less looked like a Stickler syndrome, which had retinal changes like retinal degenerations and old retinal detachment, along with high myopia. And also, we have to look for certain orofacial and musculoskeletal features in these patients. So, with that suspicion, we undertook an X-ray skull and mandible of this patient, which was interestingly showed a flattened nasal bridge, and the bit face and bony skeleton and mandible were relatively small compared to the skull in this patient, and you can see he had anteverted nares and a flattened nasal bridge. So we also called up his younger brother, who was 8 years old, and he had a very similar picture. Interestingly, he was one-eyed again. He had lost his vision to some trivial trauma during playing. So he had a physical eye with a cataract in that eye. An ultrasound showed a totally closed funnel RD. Another eye was again high myopic of -13 diopters. The fundus examination was normal for that patient, but incidentally, when this guy again came to me after 7 or 8 months of routine follow-up, he came with a certain detachment, a spontaneous detachment, for which we had to operate him for pars plana vitrectomy and silicone oil. And father's examination was again same. So the third patient was our father, 37 years old. He was also one-eyed since 30 years, and he had lost his vision again spontaneously or with some small trauma which he was not aware. And the eye was physical, and other eye was again high myopia of -27 millimeters axial length. The lens was spontaneously absorbed and dislocated into the vitreous, so it showed that he was aphakic. So we made a pedigree chart for this family, and it was interesting that both these kids, the siblings, were affected with the same disease. The sister was normal, and when we traced their parents, the father was affected, as you can see, but the mother showed symptoms suggestive of Usher syndrome. So she had night blindness and she was deaf and mute. And her brothers, 2 elder brothers, were also samely affected with deaf and mute and night blindness. And interestingly, their parents were found to have consanguineous marriage and specific term. So we took help of the genetic counselor here in this patient, and she said this is kind of an endogamous marriages, which is the practice of marrying in the same geographic location. They were not exactly consanguineous marriage, but something similar to consanguineous marriage. And similarly, the father's family also showed one of his sister being affected with Stickler kind of pathology, and their parents were also having consanguineous marriages. So the whole pedigree chart was helpful in showing that the family is inheriting some kind of a genetic disorder and look like an autosomal dominant inheritance pattern. So Stickler's, we know that it's a genetic disorder of progressive connective tissue disorder leading to collagen abnormality in various parts of the body. So thus eye was affected. Hearing can also be impaired, leading to sensorineural deafness, musculoskeletal pathologies like osteoarthritis, joint hypermobility, and orofacial features we have just seen, like small mandible, flattened nasal bridge, and can be cleft soft palate can be there. So interestingly, incidence of Stickler's is pretty high. It's 1 in 8 to 9,000 newborns, and it's usually misdiagnosed or underdiagnosed at simple pathological, basically pathological myopia, and we don't label them as Stickler's and don't look for these pathologies. Stickler's can be because of mutation in the called genes, called 2A, and different kind of genes leads to different type of type 1, 2 and 3 and 4 variants of Stickler's. Type 4 is a autosomal recessive pattern. Facial abnormalities we have already seen, and you can see how liquefied this vitreous is in this video. It's not shown, sorry. So the point of discussion here is just myopia comes to our OPD every day in and out, and we just label them, we screen them for myopic lesions like lattice degenerations, holes, and do laser barrage. But the important point is we have to look for orofacial, musculoskeletal features in these patients, identify the family members and screen them very importantly at the right time, and look for these similar genetic problems. If they have detachments, one should immediately take them for laser barrage. What type of barrage we do is an extended vitreous based laser for these patients rather than simple laser barrage. And clinical diagnosis is very important. Although you can do karyotyping and genetic genome sequencing for this patient to confirm the diagnosis, but here we diagnosed it with simple X-ray skull because patient was not affording, nor my institution was able to sponsor them. So X-ray skull was enough to make this diagnosis, and along with the clinical features, we made the pedigree chart. And another take-home message here is that apart from screening the family members and identifying the patients, even after treatment of these children with the laser barrage or retinal detachment surgery, annual screening should be done to rule out re-detachments, because they can lead to re-detachments after surgery. Any contact sport should be avoided. Counseled to avoid contact sports for these patients like football, boxing and wrestling should be avoided for such families. and they should be encouraged to use protective glasses in normal day-to-day activities while they are playing. And genetic counseling is very important in such patients, as we had mentioned in just previous cases. You should take help of a genetic counselor and should be counseled to avoid consanguineous marriages and even endogamous marriages, the practice of marrying in the same geographic location. So as we prevent the people from going, the penetration of these genes into the population. Thank you.
Very nice, very nice. I think Stickler syndrome is more common than what we can imagine. Yes, so everybody thinks Marfan's is common, but Stickler is actually more common.
It is the most common genetic
Anything you want to add, sir?
Of the connective tissue.
No comments. It's done very well, because I didn't realize that Stickler is that common and among the families. We have done a good job finding out. Yeah, it's a good job to find out siblings and distant relatives of mother and thing, and in the same area, geographic area. Yeah. That's interesting.
Yeah, we took special effort to call all their family members.
Yeah.
I think
distant relatives also.
That's a good thing you've done.
Yeah,
it's a good thing you have done a complete pedigree charting, and that's what you should do. I think you are presenting. No, you should do that.
It sends a message that you should look for others.
And also give them the proper counseling that in future, no, this possible, say they should not get married, consanguineous marriage or endogamous marriage also. Even if they get married, they should not get any children. All these we should tell them. But nowadays, the beautiful counseling techniques are there available. And I think we should make use of it. What was the visual outcome in that right eye?
You mean after the surgery? Yeah, he improved to something like 624.
624?
No, I didn't operate the detachment eye. It was a post-funnel RD. We didn't try to operate
We didn't
No,
okay.
it was non-operable.
Okay.
The other eye, which was done the prophylactic laser barrage, he was improving to 624.
With minus 18?
Minus 18 diopter myopia, yes sir. Not the operated eye.
Okay.
It was a closed funnel RD. It was beyond, because it was already going to thysis bulbi. So I was
Already,
shrinking,
okay,
low
okay.
IOP, everything. No.
Did the retina settle in the operated eye?
Sorry?
The retina settled in the other eye, operated eye?
No, operated retina was attached, sir.
Retina was attached in that
Only
eye.
laser barrage
He
was
just
done.
did a prophylactic laser barrage. But the other younger sibling, who was 8 years old, there detachment happened, and we operated very soon, because then the family was in my loop. And that father immediately brought it to me, saying that, oh, my younger son also got into detachment, and he was already one-eyed. So we immediately operated, and he was, I think, improved to 618, 625, 618, yeah, he was.
Very nice.
Because we operated immediately.
Yeah. I think it's, and there was no ectopia lentis in the other eye.
No. So, yeah, no marfonoid features.
No marfonoid features. Yeah. Okay.
So
any questions from the audience on the Stickler syndrome? Okay, thank you very much, Abhishek.
Thank you very much.
Well done.
See, we go on to the next speaker. Jaspreet is there? No. Then we have Anushri Naidu. She's available here. And she's going to talk to us on a spontaneous closure of a large traumatic macular hole, neurosensory detachment of retina.
Good morning, everyone. Spontaneous closure of a large traumatic macular hole with neurosensory detachment of retina. Macular hole is a vitreoretinal interface disease characterized by partial thickness or full thickness neurosensory defect of the center of macula. Causes of macular holes can be idiopathic, high myopia, trauma, or certain eye disorders like retinal detachment, epiretinal membrane, diabetic retinopathy, etc. A traumatic macular hole is a full thickness retinal defect at the fovea, typically resulting from blunt trauma. The treatment includes observation for spontaneous closures or vitrectomy surgery with ILM flap or peel, gas or a silicone oil injection. We report a case of spontaneous closure of a large traumatic macular hole with neurosensory detachment of retina along with a gradual remodeling of the retinal layers as depicted on serial OCT scans in a 37-year-old male over a period of 6 weeks. A 37-year-old male presented to me with a history of trauma to his left eye following a fall. The BCVA recorded in right eye was 6/6 and N6, and left eye he had a hand movement vision with no improvement. The anterior segment examination he had ecchymosis, chemosis in the left eye, and the retina examination revealed a large traumatic macular hole with the neurosensory detachment of the retina, as we can see on our OCT scan and the color fundus photograph. I did a conservative management for this patient with topical and oral NSAIDs and steroids. As we can see, just after 2 days, the OCT showed near total resolution of neurosensory detachment in this case. And as we can see, there is a centripetal migration of the cells towards the fovea. In the 6 days after the conservative management, the patient had macular hole was completely closed anatomically with the continuity of ELM and partial resolution of the ellipsoid zone. Then after 3 weeks, the patient had a more better picture with total resolution of the neurosensory detachment, and as we can see, the outer retinal bands remain mildly irregular, suggesting an ongoing photoreceptor alignment and recovery of the photoreceptor RPE junction. This is the course of the treatment. This was a presentation. Patient has the BCVA of hand movement, and on day 2 and day 3 he developed a BCVA of 2/60. And after the resolution of the macular hole, his visual improvement was 6/36, no improvement. And I did serial OCTs over 3 months, and as we can see later on, he developed some RP hypertrophy in their later OCT scans. But his vision improved to 6/36 and it remained stable thereafter. So traumatic macular hole is an uncommon complication of blunt ocular trauma. It can occur because of immediate and direct foveal dehiscence or vitreomacular traction. Spontaneous closure of traumatic macular hole has been documented, making observation a reasonable initial management strategy. There are certain favorable prognostic factors, like Mitamura et al. Suggested that younger age, smaller hole diameter and presence of posterior vitreous detachment are the factors associated with spontaneous traumatic macular hole closure. The mechanisms of hole closure include glial cell proliferation, formation of an epiretinal membrane, and reattachment of the hole through the operculum formation. An alternative hypothesis involves bridging of the macular hole by proliferating retinal tissue. To conclude, I would like to say that in my case, the remodeling was occurring over a period of 6 weeks, and using oral steroids was an effective strategy. The glial cell proliferation was the potential mechanism in this case, and I believe that observation is a better initial strategy and it avoids unnecessary surgical risks. Thank you.
Very nice. I was wondering whether it's neurosensory detachment or the PVD which became complete and the hole closed.
So the patient had
because you see that the entire retina has been lifted up. Was there any vitreomacular traction at that time?
So the patient had presented just immediately the next day. On presentation, the patient had complete like PVD. Along with that, there was a traumatic large hole, and along with that, there was the fluid which was going posteriorly from the hole.
So you said conservative treatment. So what? And did you give any treatment or just observe?
So I gave him oral steroids and topical NSAIDs and steroids further.
Do you think steroid had any role in
So
healing?
there are certain studies which have suggested the role of steroids in closure of macular holes. And even after the resurgery also, even after the normal macular hole surgery also, if there is a recurrence of hole, the certain studies from Canada and USA now say that topical steroids also are effective in reclosure of the hole without the surgery.
How long was the follow-up?
So I followed up the patient for now almost 6 months, and after that he didn't come for follow. Now I call him at 6 months.
No, was there any Berlin's edema at that time? Because if you look at the picture there, and also the OCT does not appear to be full thickness. If you go back on the.
They have changed the presentation.
Can you have the slides again, please? Show the fundus picture. It's a blunt trauma, no? It's a blunt trauma. Whether there any Berlin's edema was there and
There was
that got settled down.
Full thickness hole of the macula.
No edema.
No, there was bare minimum edema for this patient.
Yeah, that's what I'm telling. Ah. Yeah. And also, I feel is it in the macula, slightly parafoveal?
So it
If you see the photo, the macula, yes, it's slightly, why the macula is slightly on top superior.
appears to be
See, there is some white spot there, no?
Yeah.
So whether there's some sort of edema there, Berlin's edema, I'm wondering whether it's a true macular hole or something different.
but it is separated anyhow.
Yes, sir. I have a doubt whether it's a pseudomacular hole or because it's not in the. If you look at the where's the macula in that? Can you show it in the with your yeah? No, because macula is straight. You have to see macula is not higher level than the disc. No, I'm talking about the fovea.
So
Okay, not the macula. Macular is a bigger area. If you take the fovea, it's straight from the disc. It has to come. No. थोड़ा ऊपर है. You got the point, and you are taking the scan right there. It's parafoveal actually, because the fovea is got the Berlin's edema there. What you see whitish area, just slightly above that is the fovea. Can you just put the arrow there? No, this side, on the picture, on the frontis picture.
Yeah. Here.
Yeah, that is yeah.
Yeah.
No, the white spot is there. No, white spot next to it.
This one.
Yes, that's a Berlin's edema probably. Look, slightly put the arrow up. Slightly to your right, that will be the that will be the fovea. Slightly to the left. Slightly to the left. Yes, correct. No, you put it there. Slightly to the left. To the left. Left, ma. Yes. Somewhere there will be the fovea. So I was wondering whether we are missing something else there.
Did you do multiple scans?
Yes, the multiple scans were done,
Five
like
line.
when the Rhine and the raster both were done.
That would show whether it is macula.
So
or
it
fovea.
was involving the entire region only. It was slight parafoveal in appearance, but it was a complete hole, full thickness hole.
Okay.
Because you said, because I don't see the PVD also there. Because otherwise in OCT you should be able to see the PVD there, full PVD. Whereas any other scan is able to pick it up. So we have to see the serial scans.
So these were
Whether
the-
there's some sort of traction on the macular hole, on the inner retina by the vitreous. And when there is a spontaneous, when the injury occurs, no, so this spontaneous PVD could have occurred and the hole would have, and the entire retina would have gone back and hole closed. That's my presumption of this. Anyway, it's a good thing. Thank you very much for that. Any questions from the audience? Okay, thank you. And we go on to the next speaker. Dr. Bilal Ahmed is there. No. Indranil is there. Shivaya and Srivatsa. And he'll be the last speaker. Sujay is not there, no? Why so many people are absent?
Good morning.
It's not correct, no? Yes, sir, all of them are.
I'm Dr. Shivan and I'm going to be presenting on prophylactic buckling in retinal capillary hemangioblastoma, early intervention to prevent progression in one-eyed patients. So we had a 29-year-old female presenting with diminution of vision in right eye for the past 3 years. She had history of trauma in the right eye by her child's hand in 2020, followed by gradual painless diminution of vision for 6 months, followed by sudden loss of vision. She presented on 3rd October 2024 with vision of no PL in the right eye. She had history of laser in both eyes with no surgical intervention done outside with no documentation available. She had no history of any systemic disorders, no history of ocular surgeries, no history of using any high-powered glasses, flashes and floaters, no relevant family history. Coming to examination, we noted that she had no PLI in her right eye. Her left eye was within normal limit with refraction improving to 6/9. She had total hyphema in her right eye, and on ultrasound, B-scan showed a small sized globe with disorganized intraocular contents with moderate homogeneous spikes in vitreous cavity. In left eye, we noted a superotemporal active angioma which was partly lasered with fibrous traction. The FR was dull with a grade 0 ERM and laser scars were present inferiorly with a laser regress angioma. So coming to the Optos clinical picture, here the first thing that we see is a superotemporal protuberant nodule, followed by a feeding arteriole and a draining vein. Then then we can see a few laser spots in the retina, and then inferiorly a few red nodules, and in the fovea we can see a grade 0 ERM. Based on this, our differentials were retinal hemangioblastoma, vasoproliferative tumor, and retinal artery macroaneurysm, out of which the most 4 points were for retinal hemangioblastoma because of age of onset, the presence of feeding and draining vessels, and the peripheral site of the lesion. So based on this, when we went ahead with an fundus-fluorescein angiography, in the arterial phase, we can see the feeding arterioles feeding the tumor. Then in the early venous phase, we can see the draining vein. And then in the late venous phase, we can see a leak over the lesion, followed by laser scarring, staining of the laser scars. And inferiorly, we can see multiple small hyperfluorescent masses, 3 inferiorly and 1 superiorly. Then we elicited additional history. She had no history of any auditory symptoms, no history of excessive sweating, panic attacks, no relevant family history, no history of headache, abdominal pain, or blood in urine. Coming to systemic evaluation, the MRI was within normal limit, the audiometry was within normal limit. The ultrasound abdomen revealed multiple cysts noted in the head, body, and the tail of the pancreas, averaging 12 into 14 millimeters. And kidney showed simple cyst at the upper pole, which was 44 into 34 millimeters. So the provisional diagnosis of retinal hemangioblastoma VHL was made based on the Danish criteria and international criteria. It requires, as she had negative family history, it required 2 VHL-related manifestations, out of which she had retinal hemangioblastoma and multiple pancreatic cysts. So previous studies have shown that laser treatment can be considered as the primary form of management for the management of retinal hemangioblastoma. So we decided to do direct laser over the small hemangioblastomas and feeding arteriole lasers for the large hemangioblastoma in the initial settings, followed by laser spots over the hemangioblastoma, and regression was monitored. On 1 month follow-up, regressing hemangioblastoma with traction was noted. In this Optos CP, we can see the lesion with peripheral tractional retinal detachment and traction. So in view of this, we diagnosed the patient as left-eye multiple laser retinal angiomas with superotemporal regressing angioma with traction. And we decided to go for a buckling procedure, which has been done previously in cases of large hemangioblastomas along with plaque brachy. But in our case, as the tumor was regressing, we decided to go for left-eye buckling with a single freeze-thaw cryotherapy of hemangioblastoma under LA. On post-op medication, she was started on topical steroids and a short course of oral steroids, and topical antibiotics and cycloplegics were given. On post-op day 1, we can see the cryo mark with subretinal fluid around the cryo mark, which is an expected finding. However, on post-op day 2, we saw that there was an increase in the extent of the subretinal fluid, with the cryo mark can be still visible. So post-op day 2, her vision had dropped to 636. This was a one-eyed patient, so it was a bit serious. And she had anterior sanguine findings which were within normal limit, and the SRF noted in the superotemporal quadrant with cryoburns. But on 1 week post-op, because of the steroids and the topical steroids, her vision came back to within normal limit what she had before. The resorption of subretinal fluid was noted, and repeat laser of hemangioblastomas was done after 1 month. This was a 1 month follow-up in which we see that the mass is regressing, the traction was resolved, and grade 2 ERM was seen over the foveal region. So retinal hemangioblastomas are present in the second decade. There are multiple tumors in cases of VHL, and the cause of loss of vision can be multiple, ranging from exudation, traction, complication, and secondary manifestations. In average range of presentation of retinal hemangioblastoma is 25. So it is the earliest manifestation of VHL disease which is seen in individuals. So the take-home message is that understanding retinal angioma is crucial for the timely diagnosis and management and to prevent visual loss. The clinical presentation can vary widely, but thorough evaluation should be done. And syndromes like VHL should be recognized, and screening of other eye and family members is a part of the timely management of the condition, and that can prevent vision loss in such patients. Thank you. Thank you.
Very nice, very unique presentation, Shiva. I'm wondering whether any role of anti-VEGFs?
Sir, anti-VEGFs have they have been noticed to have a role, but there's a newer agents like bezulotifan and all, which have been noted. They are HIF inhibitors, which have been noted to play a role in the management in VHL patients especially.
What buckle you used, and you used a circumferential or radial buckle?
Sir, it was It was a segmental buccal, circumferential buccal. So
What is the size?
Sir, it was 276 asymmetrical buccal with posterior extent more than anterior.
276.
277.
7.
Sir.
Okay.
How do you do laser in these?
Sir, in cases of small hemangioblastomas, they are lasered directly. But in cases of large hemangioblastomas, we have to laser first the feeding arteriole, followed by laser over the hemangioblastoma. Then we can laser the draining veins. And in the meantime, we also have to make sure that the laser we are giving is of longer duration and it is of lesser power.
I wanted to know the feeding. In first sitting, you should do laser around the feeding vessel.
Yes.
And
Around the vessels.
I would do laser, heavy laser around the feeding vessel.
Yes.
Leave it for 1 week for it to shrink.
Yes, sir.
Leave it for 1 week. And then do on the main mass.
Yes.
And use very large
Yes.
size
Large
and heavy
size
pumps.
and large duration.
In my days when we had xenon arc photocoagulator,
Yeah.
so we used to do xenon arc, which were more effective than laser, because xenon arc is a much bigger spots.
Bigger spot size. And delivered to the direct to this thing, xenon arc. I remember my chief, Dr. Badrinath, used to do that regularly, sir, that time, xenon arc. And because the cryo is probably one of the best for hemangiomas.
Cryo is effective.
Triple freeze thaw technique, you can use that. Because you'll be able to cover the entire lesion, because it's quite a big laser will not be able to cover.
So one thing that we noted in the case was that the buccal indent was not as posteriorly as we would have liked in this patient. As in the opto-CT, we could not see the posterior indent over the lesion, but still
Yeah.
the traction had resolved, so the patient was asymptomatic at that time.
Even the transpupillary thermotherapy is good, TTT.
Yes.
We do that for hemangiomas that time. Now it's not available. Not that it's not available. We are not using that much. So, any questions?
Thank you.
Thank you, sir.
Thank you, Shivayan. And we have come to the, I think Sujay is not there, no? So we come to the end of this very interesting session. We had some very nice cases presented by people who are really interested in presenting, coming on a Sunday morning. And so many people are absent. Even the chairpersons, and had the fortune of having Professor R.B. Jain with me here. And sir, you would like to make some comments, sir?
I think it's a very nice presentation by young ophthalmologist, and especially a topic which is not interesting to general public but very important.
Yeah.
People should realize that genetics is an important part in management of patients, because if you are not treating a eye, you are treating a patient, you are treating a family.
Correct.
So you should really look at the patient and the family as a whole. So if you want to be successful in management of a patient. And Dr. Mohan said, thanks to the speakers for who made it. Even the moderators don't know. I am a Stepney here, so it doesn't matter.
So bad. Anyway, we'll have a group photograph. Speakers, please come forward.